Okay, we're starting on chapter 8. The PowerPoint is titled Assessment Techniques and Safety in the Clinical Setting. The other two PowerPoints you'll want to get ready. We're going to try and power through these. General survey measurements and vital signs, and then pain, the fifth vital sign. So if you want to take a second to get those loaded or pause me and get those going, we're just going to jump right in. So, cultivating your senses. So physical examination requires you to use all of your senses, right? So from the moment you put eyes on your patient, you're starting to do your assessment. So you're watching them walk, you're looking at their posture, you're looking at their skin color, and you're using all the tools that you have, right? So I like to get my own patient because I can do that. I can see how they're sitting when I call their name in the lobby. I can see how they get up. I can see how they walk or how they're in a wheelchair. So I really want to use as much of your senses as you can. And then we're going to talk about the technical skills: inspection, auscultation, palpation, percussion. Inspecting is what you're doing when they're walking in the room. You're talking to them. You're inspecting how they interact. Auscultation is listening with your stethoscope or just listening to them talk. When it comes to assessing things like the abdomen or chest, anytime you're going to palpate something that you can listen to, you always want to look, listen, then feel, because you don't want to. One for like abdominal assessment, you don't want to press all around on the belly and then listen to it, because that can create vowel sounds and things like that. But percussion is something we will talk about very briefly, but it's not really used that often anymore. First is inspection. Like I just talked about, as soon as you meet or see the person, you're inspecting, you're looking, you're doing all the things. You want to make sure you have good lighting. You want them to be in a gown if that's appropriate. Use instruments as needed. That would be, if you're inspecting a wound, you would measure it with a measuring tool or something like that. But you want to just take in as much information as you can just by looking at the patient. Palpation. So you can learn a lot from touching a patient. You touch their skin. Is it warm? Is it cold? You can feel, pulses. Crepitation is like it's air pockets under the skin, and it kind of feels like you're pressing on Rice Krispie treats. Different parts of your hands feel different types of things. So skin texture, fingertips. Fingertips are how you check a pulse. Check for lumps. Determining temperature, you want to use the dorsa of your hand. So the back of your hand is how you're going to check the temperature. Just like, people do when they are checking temperatures, they put their back of their hand on your forehead. And if you're trying to feel vibration, you use the palmar surface of your hand. Percussion used minimally. This is a kind of an old assessment technique before we had a lot of things like ultrasound and x-ray and CAT scan. And basically direct percussion is, you put your hand here and then you were going to tap on your hand. And so I'll let you look into this if you're curious, but if it's dull, you're over something hard. If it's like a high-pitched noise, it's hollow. And then that's indirect. And then direct is just striking directly onto the skin and percussing. I'll still see a doctor who's been doing this for 40, 50 years. I'll still see them do a little bit of percussion every now and then, but pretty rare anymore. Auscultation, so we're going to listen. Stethoscope, super important. You want to use the diaphragm when you're listening to breath sounds, vowel sounds, heart sounds. That's the bigger side. You want to press firmly. I'm really excited about the sim lab this semester. We have the ability to actually listen to heart sounds and breath sounds, and they're very realistic. I spent a day listening to all of them, and I'm really excited for you guys to hear the different things. But when you're using your stethoscope, you should always use the stethoscope on the skin. So if I'm wearing this shirt, the stethoscope needs to go on my skin to listen. So that's really important. I don't want to see any of you ever listening with the stethoscope over shirt. So if you aren't able to listen to the skin on your partner in class, then I want you to do it on the mannequin so you can get that experience of actually listening on the skin. The bell or the small side, that's how you're going to hear like murmurs, and you lightly touch, you know, like if they had a carotid bruit, which is like clot or some closing where it caused some vibration sounds, you would lightly listen to the bell right here on our carotid. This talks a little bit about the setting and things that you need. I'll let you read. This is a very detailed equipment list, so I'm not going to read through it, but this is, you know, all the stuff you could possibly need for your full head-to-toe assessment. Hand hygiene. Wash your hands. Wash your hands literally always. When you're thinking about what you're going to do, wash your hands. Really important when you're in the lab setting. Every time you walk into the lab, I want you to hand sanitize. When you're interacting with the mannequins or your partner, your peer, I want you to hand sanitize. It should be real. When you're in the lab and you're in this situation, you just want to get in the habit now. So sanitize. If your hands are getting to the point where there's too much sanitizer on them and you're getting kind of filmed, then I want you to wash your hands. This is like the #1 thing that prevents spread of microorganisms or bacteria. So especially during a pandemic, you know, you really want to wash your hands. I have hand sanitizer in my purse, in my car. It's everywhere in the hospital, so just get in the habit now. You know, when you wear, I think a lot of people, they put gloves on and they think that's a full barrier, but some, you know, they say that actually some microorganisms can transfer through gloves, which is really gross if you think about it. So wash your hands before and after physical contact with the patient. And yeah, that should be like the number one rule. That if you can't remember anything from all these lectures, remember to wash your hands. Standard precautions, you know, that's kind of, if you're doing something that causes a splash, you want to wear eye protection. There's a table in either your workbook or your textbook that goes a little more into detail with this, but we'll talk about PPE and things like that later. So this is a good question. Nurses preparing to do a physical assessment on a patient who's end-stage HIV positive. What should the nurse do for protection? And #1, wash hands, don gloves, gown, and protective face shield. Don gloves, wash hands. After exam, no other protective equipment necessary. Wash hands, don 2 pairs of gloves and the gown. Wash hands, don gloves, and wash hands after examination. No other protective equipment is necessary. So think about that for a second. So wash hands should always be first. #4 would be the correct answer. If you're just doing a basic physical assessment, there's no need to gown, wear a protective face shield. You would wash your hands. You put gloves on because if you're gonna do a full assessment, you could end up touching, you know, look in their mouth and things like that. So you want to have gloves on and then wash your hands after. Okay, assessment techniques PowerPoint is done. We're going to move on to general survey, measurement, and vital signs. So general survey, you're done all your history, you've talked to them, you're inspecting them as they look in, and you're kind of starting to do your assessment of the whole person. Do they look sick? Are they interacting with you normally? Are they acting bizarre? This is a part, I'm not going to have you do this because you guys are all probably at home, but you know, it's the theory behind shaking your classmate's hand. Like, what do you learn from a handshake with someone? You know, if someone's very ill, you know, do you obtain information from that? So there's a lot you can learn from simple interactions. So general survey, for the major areas: physical appearance, body structure, mobility, and behavior. So physical appearance, you know, am I You know, someone who comes in and I look like I'm 65, but you look at my chart and I'm actually 28. You know, that should tell you a little bit about the person. So are they, you know, homeless and have a lot of mental health that really causes them to look disheveled? You know, are they a heavy drug user that's caused them to age quicker? Have they been, you know, do they have some sort of genetic disorder that makes them look older? Let's see here. We talked about gender and sexuality again. Just, you know, asking them respectfully what pronouns they like to use, and addressing them the way they want to be addressed. You know, are they alert and oriented? Do they answer your questions appropriately, or are they confused? Or when you ask them a simple question, do they seem to not know what you're asking? What's their skin color? Is their face, everything moving symmetrically? No signs of acute distress. So how do you know a patient's not in acute distress, right? So if you're assessing me right now, you could easily chart that I'm not in any acute distress. So the ways you could say that is patient resting comfortably in her chair, her respirations are equal, they're non-labored, and so that tells me that you're giving me objective signs that I don't appear to be in any acute distress. So then you could say no apparent distress noted. Body structure, stature, body build, nutrition. Like, do they look healthy? Do they look too thin? Are they overweight? How's their posture? You know, especially when people are in pain, they can be bent over. A lot of psychiatric patients, you know, they can be kind of like defensive or kind of paranoid, and that tells a lot about a person. Some congenital deformities. There's some really kind of intense pictures on the next slide. That up top left is Cushing syndrome. You know, that's obesity due to Cushing's. On the right is an anorexic patient. Bottom left is really interesting. Both the patients are 9 years old, but the one on the left has a growth hormone deficiency, so they're not growing the way they should. The next slide, the patient on the left has a connective tissue disorder called Marfan syndrome, and on the right, this patient has dwarfism. So some objective data when we're looking at the general survey is their gait. So gait means how do they walk? You want to watch them walk if they can. So are they are they limping? You know, do they appear to be walking normal, even wide, or even stride? There's a video on here if you want to pause this and watch. It's a very old video, but it's a good demonstration of how a patient with Parkinson's, their gait walk, what it looks like. Okay, so here's some more objective data, their behavior. So do they maintain eye contact, or are they, you know, staring at the ground and they'll look at you only for a second, or are they just staring at their partner, their friend? How do they interact with you? So is the patient calm and cooperative? Are they pleasant? Or, you know, are they, you know, irritable every time you ask them a question? You know, these are your objective findings, right? So they are, if the patient is very short in answering questions, you find an objective way to describe the way they're responding. So how a patient talks. So I speak probably kind of quick right now, but fluent, even pace. I'm trying to be clear. I hope that it's coming across clearly, but you want to make notes about that, because if, you know, especially if the patient has had a stroke and they struggle to find words, you want to note that. That's an important assessment. And dress, this is, you know, are they clean? Do they look disheveled? Is it 100 degrees outside and they're wearing a winter coat? You know, things that would point to a good assessment of ability to adapt to their surroundings. Okay, measurements. So really important to get a patient's weight. Can you think about why it would be important to get a patient's weight? One major thing for me where I work is a lot of medications are given based on weight, so very important to weigh them unless they've had a recent weight, and then ask them how tall they are. Body mass index, I kind of have my own personal bias against body mass index because it really can be not very accurate. So you can be, you could be a large person who's very fit, who runs marathons, who's actually very healthy, but you just have a bigger body stature, and your BMI could be really high, but that doesn't mean that you're unhealthy or overweight, right? So it's a weight to height ratio. There's a calculation there. If you'd like to work on calculating your own, that's fine, but it is a number that you can use as a tool, but I wouldn't rely on it 100%, I guess is what I'll say. Your waist circumference can assess your body fat distribution, which could be, if it's a very large waist circumference to the rest of your body, it can be an indicator of health risk. Okay, vital signs. We're going to practice these in the lab this week. So first one here is temperature. Average temperature is 37.2. 37 is 98.6, which I think is kind of what we all know as normal. Temperature is regulated in your hypothalamus. And these are just some things that influence your temperature, right? So if you exercise, you increase your body temperature. That's very obvious. The rotation of the sun, diurnal cycle, menstrual cycle can cause a rise in temperature. And I think we'll go into some ranges here on the next slide, but just knowing there's infants and young children, they have less effective heat control, so if you have an infant or a young child that has a fever, often if you just get them undressed and expose them to the air, it'll bring their temperature down pretty quick. But their mean temperature is 36.2, or average temperature 36.2. It's a little bit lower. Okay, so our routes. We're going to practice all of these in lab. So, and I want you to discuss when each one is the appropriate temperature, right? So, oral temperature is the oral thermometer under your tongue. A normal oral temperature is 37 degrees. Really want you to get familiar with Celsius. Celsius is the standard of temperature measurement now, so your ranges are on here. When you would do a rectal temperature, so a patient who has a severely high fever and you're concerned, you need a very accurate temperature, so you would do a rectal temperature, and it's going to be a little bit higher than an oral temperature because it's in the core of the body. Axillary, really only used for children and infants, and in pediatric settings, that's you put the thermometer under the armpit, hold it there. Tympanic membrane, this is the one that goes in your ear, you're going to hold it there. And temporal artery, that's the one that slides across your forehead. That one's very convenient, and nurses really like that one, but there is some conflicting research that says that this might not actually be a helpful, or the results might not be very accurate. So times to use that are patients that have no infectious process, or you're not at all worried about a temperature. That would be an appropriate time, but if you're concerned about infection or high fever, you would really want to get a more accurate result. So here's a little more information. Lips closed 3 to 4 minutes on oral. That's if you're using an old school thermometer. Most automatic ones are a lot quicker than that. Take other vital signs during this. This is when you want to check their respirations, because you don't want to tell someone you're watching their breathing, because then they'll start breathing a little bit differently. I don't know why, it's just human nature. But rectal, this is, so comatose, confused, can't close mouth. You don't want to do rectal temperature on an infant, especially because you could perforate their bowel or their rectum, which is not good. Another note with a rectal thermometer is you want to select the correct probe. So don't use an oral thermometer on somebody's rectum, right? Gross, that's disgusting. So you will have the opportunity to try this on the mannequins. I actually haven't looked to see, but we're gonna make it happen one way or another. Another thing to note on an oral thermometer is think of reasons an oral thermometer could be altered. So did your patient just drink hot coffee? Did they just drink ice water? You want to wait at least 5 to 10 minutes if that has happened, just to get an accurate temperature. Tympanic membrane, that's super easy way. Put the thermometer in the ear and check that. See, when you use the tympanic membrane thermometer, you want to make sure you know how to use it and you're putting it in the right place. That's the big thing with that. Here is your temperature scales. You should be familiar with both because, one, your patient wants to know Fahrenheit. Your patient doesn't know what 37 degrees Celsius means. So I usually, I know a general range. So if a patient's, if it's 37, I know I can tell them it's 98.6. And if it's 40, I know it. I think 40 is 104. So I have a pretty good idea. But Celsius is the way we should be documenting it. So if you work somewhere that doesn't have an electronic system and you need to find out, this is the equation here. Degrees Celsius equals 5/9 times Fahrenheit. The Fahrenheit temperature minus 32. Or if you need Fahrenheit, this is the opposite of the equation over here. So I would take a minute and just do these equations just to get familiar with it so you can see the scales. But the nice thing is most places have electronic health records now, so it will do this calculation for you. Okay, assessing the pulse. Pulse can tell you a lot about a patient. It gives you the rate and rhythm of the heartbeat. For assessing the radial pulse, it should be pretty easy to find. It tells you, can give you, it can tell you that the artery has good peripheral vascular resistance. And when you measure a pulse, you want to most commonly, radial pulse, count for 30 seconds. If it feels irregular, you want to compare to the apical pulse. Apical pulse is listening to using your stethoscope and listening to the heartbeat and comparing with the pulse. You can do a 15-second interval when you're checking a pulse, but it can be up to a 4-beat error if you do this because of the 1-beat error that can happen between 15 and 30 seconds. Here's some normal ranges for you. So less than 60 is bradycardia, over 100 is tachycardia, and in the middle is normal. These are for adults, of course. Pediatrics have a whole different range. The strength of stroke volume, this is the pulse, right? So a normal pulse is basically a 2+ pulse. So if you feel your radial pulse and you're normal and healthy, that's what a 2+ feels like. And on the sim and essential, we can change the pulses to make them weaker bounding, so we'll work on that. Do some practice there. Respirations, this is when you're doing anything else, you want to count their respirations. So when you're checking their pulse, you can be looking at them, or when you're checking temperature, you can be counting the respirations. What I sometimes will do if I'm checking the pulse, I'll do my pulse count for 30 seconds, and then the other 30 seconds I'll watch their respirations. And a regular adult respiration is 10 to 20. Okay, blood pressure. We're going to practice this in lab this week as well. Systolic pressure is your top number, diastolic pressure is the bottom number. So what systolic pressure means is the maximum pressure during your left ventricle contraction. That's systole. In the cardiac lecture, we'll go way into this. You'll love it. Diastolic pressure is your bottom number. That's your resting pressure between each contraction. This is kind of morbid, but the way I have always remembered systolic versus diastolic is when you die, you're in the ground, so you're on the bottom, and the diastolic is the bottom number. It's still, every time when people ask me, I still think about that in my head for some reason. So, the mean arterial pressure is the pressure forcing blood into your tissues. And we'll go into this later. You guys have a lot to learn this week. So, but it's basically your systolic plus 2 times your diastolic divided by 3. This is really important for critical patients. So if you are really sick and you have a low blood pressure, which is hypotensive, then if we give you medications, you titrate to a MAP now. We used to titrate to a certain blood pressure, but now we titrate to a MAP. For the MAP, there's a saying that we say, and it's MAP above 55, staying alive, but really, we usually want the MAP to be, MAP above 65, staying alive, but a MAP of 70 is really a better pressure to get your brain perfusion. So you really, if it's not above, if you get 60, you start to lose brain perfusion, and so the patients can start to get loss of tissue and confusion when that happens. Average blood pressure, 120 over 80. These are just some reasons. Things can be lower or higher. You know, a lot of young women have a little bit of a lower blood pressure, and that's just from genetics. Here's some blood pressure factors. I'm not going to go into this. You're welcome to look this over. We'll talk more about this when we get into the cardiac lecture. And here's another slide kind of showing the cardiac output, vascular resistance, all the things that can affect the blood pressure. An auscultatory gap is when you're checking the blood pressure. It occurs in about 5% of patients, and you're checking the blood pressure. So when you lose the pulse, you're either gonna palpate or you're gonna listen. And when you lose the pulse, you want to pump up the blood pressure cuff 20 to 30 millimeters of mercury higher, because you can lose the pulse when someone has a really high blood pressure, and then actually you'll get a normal blood pressure when actually their blood pressure is very elevated. So you always want to pump up higher to make sure there's no pulse sensation a little bit higher. And they actually have a blood pressure of 220 over 120 when you thought it was 140 over 80. This is how we're going to check a blood pressure, sitting or lying down. You want them to be relaxed. If you're doing a manual blood pressure, you're going to palpate the brachial artery, which is right about here. And you're going to put the blood pressure cuff on above. You want to ask the patient always if it's okay to take a blood pressure cuff. Some women who've had mastectomies or lymphectomies, they can't have a blood pressure on the arm. So make sure to ask, because they won't always tell you. So you're going to palpate the brachial artery, which is sometimes hard to find. And then when you lose the brachial artery, you want to pump up 20 to 30 millimeters mercury higher, and then you're going to deflate the cuff evenly and completely. You're going to identify what number you need to inflate 20 to 30 higher. And then you're going to use your stethoscope. You're going to listen to the brachial artery. You're going to inflate the cuff to that level that's 20 to 30 higher where you lost the pulse. Deflate really slow and even, about 2 millimeters of mercury per heartbeat, which you can see on the monitor. There's a really good video on the Evolve to show you this too. You just want to note when you hear the first sound and when it goes away. And that's your systolic and your diastolic. You want to record your blood pressure using even numbers, and you want to talk about were they sitting, were they standing, were they laying down, which arm was it a regular size cuff, was it a large cuff, or was it a small cuff? So, and when you document your pulse rate and rhythm, and I would say the same thing for respirations, is whether the pulse is regular. So if you're checking the pulse and it's regular, and then there's, you know, a quick beat in there, and then it goes regular again, you want to make a note of that. Same with respiration. Sometimes people will breathe normal, and then they'll have like 2 quick breaths or 1 big deep breath. You want to just note that. Some pictures of measuring blood pressure. Some ways that your blood pressure, like if you have a way to, if you used an extra large cuff on my arm, it would not be helpful. And also if you use a really small one, it might not be big enough, so you want to make sure you have the right size, and make sure you take the time to do it accurately. The white coat syndrome is a thing that happens, you know, you'll check in a patient with very high blood pressure. A lot of people just don't like going to the hospital or to the doctor, and usually once they calm down a little bit, their blood pressure will go down just a little bit. Orthostatic blood pressures. This is something that you use to measure basically like low fluid volume. So is this patient dehydrated? And we'll go over that procedure in just a second. You can also get blood pressure in the thigh. Very uncommon, but you can do it. Ankle brachial index is an assessment for peripheral vascular disease. I'm not going to go over how to do this. You're welcome to look it up if you'd like to. A Doppler blood pressure is something you'll see in like a critical situation, and that's when the pulse is so faint that you can't hear it with a stethoscope or a palpation. So you actually use a Doppler and put that on the artery, and then you'll do a blood pressure doing that to see if you can hear it. We talked about the oscillatory gap. A palpable blood pressure is if you did that brachial pulse and you did a blood pressure, you could feel the top number, you know, so you wouldn't be able to really identify the bottom number. So you could say their blood pressure was 140 over palp, and that just means you can't document the bottom number because you can't hear the stethoscope. Okay, orthostatic vital signs. I do these a lot in my work. You want to lay the patient all the way flat. That's our work for supine, right? You want to wait 2 to 3 minutes. Anytime I do this, I have the patient on the cardiac monitor as well because I have that capability, but they don't necessarily need to be on that. But we're assessing to see if they're dehydrated. So they're laying flat, and we're going to check their blood pressure, and we're going to check their heart rate, and we're going to document that. And then we're going to have the patient sit up. And then once they sit up, you're going to do another blood pressure, and you're going to watch their pulse rate. So you want to see if their pulse rate goes up more than 10, 20, that's telling you that they're hypovolemic or fluid volume low. So they're either need fluids or they need blood. So 10 to 20, and then check their blood pressure, and if their blood pressure drops, that's another sign that they're hypovolemic. So if they sit up and they are severely dizzy, do you think you should continue with the procedure and stand them up and do the same? No, don't do that. You don't want your patient to pass out on you. You have to do a whole incident report. So if they sit up, blood pressure, pulse, normal, or even if the blood pressure drops a little bit and the heart rate goes up a little bit, but they feel fine, then you want to stand them up. Important to note, when you sit them up, you want them to sit up on the side of the bed and their feet should be dangling. And so if that one goes well, then you stand them up, and then you check their heart rate and their blood pressure again. So looking for heart rate to go up and blood pressure to go down, and then that means that they're hypovolemic. That would be a positive orthostatic. Yeah, so that's a really good assessment tool, actually. You can read this if you'd like. This is how to do a thigh blood pressure. There's a picture of it right after it to kind of show you the procedure here. This is how to do an ankle brachial index. Again, this is a very uncommon assessment tool, but you basically compare the ankle pressure with the blood pressure on the arm, and it tells you whether or not the patient has peripheral vascular disease. So here's some infant and children developmental considerations. But like vital signs are a lot more difficult. They can be a little more challenging. The ranges are all very different for children. The textbook goes over the details of different ones. So if you're curious, but a higher heart rate in an infant is normal. A higher respiratory rate in an infant is normal. Yeah. Some more infant and children measurements. You can go through their growth chart, things like that. We're not going to go into depth on the growth patterns of children here, but there's plenty of information in this in your textbook if peds or infants are something that you're interested in. Getting height and weight and head circumference is an important thing. If you are working with kids, you really want to get an accurate height. This is a good picture of how to do that. This is how to get their head circumference measurement. And then you want to get a measured weight on kids always. You never want to get an estimated weight. Okay. Here's some more developmental considerations for the elderly population. Their bodies start to change a little bit. There's a picture in here that kind of shows you the redistribution of things. The discs shorten in the spine. This is how their vital signs are affected. I'll let you go over that. Excuse me. And then there's that picture of the woman. Some other vital signs. Pulse oximetry. This is another thing we'll practice this week in lab. It measures arterial oxygenation. It really measures the peripheral oxygenation. You want to use the right pulse oximeter. And if the patient doesn't have good circulation, you're not going to get good readings. So you might have to use like the ear pulse oximeter. Sometimes there's forehead ones. And pain is another vital sign, which we have a whole separate PowerPoint to go over that. Okay, so the nurse is assessing the patient with a heart rate of 55. Which of the following patients would be most likely to have a pulse rate of 55? I'll let you read these here yourself. So number one, a 70-year-old man, he's probably going to have a high heart rate because he's dehydrated, so his body should be compensating a little bit for that. A 20-year-old runner, people who are in good physical cardiac health will have a low heart rate because their bodies have adapted to that. So that is our answer number 2. A 67-year-old with a COPD exacerbation is going to have a higher heart rate who's probably working hard to breathe. Probably got some albuterol, which makes your heart rate go up. And then an infant infant has a heart rate of 55. You should be thinking about starting CPR. They often have a higher heart rate. Here's some just difference about genetic body proportions for you. I'm not going to go into that. Here's a really good sample charting. So if you're doing a note on a patient, 56-year-old Hispanic male construction worker who appears healthy according to stated age. He is alert, oriented, cooperative with no signs of distress. Height 5'7", weight 182 pounds. Temperature 37 degrees Celsius, pulse 84 beats per minute. Respirations 14 per minute, blood pressure 146 over 84, and that's in the right arm, and the patient is sitting. Really good. Would you think that's subjective or objective? So that's your objective assessment there. Okay, so we are finished with that, and we are on to the pain assessment. So go ahead and get that one loaded. Okay, pain, the 5th vital sign. This is chapter 11 of your textbook. So, a 52-year-old female, this is a case study, presents with complaints of continuing pain across her lower back. She denies any injury or traumatic event, but states that the pain is a 10 on the scale of 1 to 10, and that no one believes that she's really in pain. The pain has been present for several months. So what are you going to do? When are you going to start with this? So you're going to ask her more about the pain. You're going to ask her what's different today. The pain's been going on for months. What has she tried in the past? What was she doing when it started? Try and you also want to reassure her. She probably has legitimate pain, and in this day and age, like so many people have chronic pain and are addicted to narcotics, that people get a little callous. So maybe no one has actually listened to her or taken the time to do a full assessment. So kind of reassure her. You can offer her non-pharmacological pain relief until a physician or provider can see her. So a warm pack to the lower back or an ice pack. Either would be fine since it's been going on for so long. Then you want to go into your PQRST mnemonic. So just assessing it the same way, and sure, she could be lying and this could be an attempt to get narcotics, but she also probably legitimately has some pain that you could help try and ease. Acute pain, that's identified as short-term, often self-limiting. So if you have an injury and then usually it goes away, it's not necessarily true, but examples of this are like someone that comes in with a kidney stone. That pain comes and goes, so it comes on severe, very, very intense pain. And then once the kidney stone is no longer stuck in the ureter, it can actually be, the pain can go away. Or if a patient has appendicitis and the appendix bursts, often the pain goes away when that happens. It's unfortunate, but it does happen. And that's your body's way of saying, like, hey, something's going on. I need you to pay attention and get it looked at. Chronic pain is considered pain that lasts for longer than 6 months. It can last way longer than that. It can be caused by cancer. It can be any like arthritis. Chronic back pain is a really bad one. Developmental competence, right? Difficult to assess pain on an infant, but they can have pain, they experience pain, so you have to use your assessment techniques, like, is it a normal cry or is it a severe cry that seems like the patient is in pain? And older individuals, their pain tolerance usually is the same. In my experience, the elderly population when it comes to pain, are the same as regular adult patients. One thing to know with elderly patients is narcotics are very constipating, so if you are giving them, you really want to do some education on prevention of constipation, because in elderly patients, bowel obstruction can be pretty detrimental. Some gender differences of pain. I mean, some people are just tougher than others. I think it has something to do with how you were raised, how your genetics, your hormones. Some women, when they are, like, their hormones are elevated, they are more sensitive to pain. So just being aware of that. Cultural differences of pain. There I've seen, it's hard to say, but it seems like every patient has a different pain tolerance. Sometimes culture difference will go into it. They have a very stoic culture that does not want pain medication, or is very unlikely to take it, or the opposite. They're like, I'm in a little bit of pain, I really want pain medicine. So just, again, being aware. So pain is subjective, right? So you can experience their pain. You can't, even if they look in pain, it's the patient's perception. It's how they describe it to you. So, you can do an assessment, find a diagnosis such as an appendicitis or a kidney stone, and then that can support the patient's subjective symptoms, but it's kind of a hard one to say is objective. Initial pain assessment, we've already talked about all of these. Doing your PQRST, super important. And here's some ways to ask those questions. And then words used to describe pain, this is on slide 9. Every single patient I document one of these words if the patient has pain. So these are important to get familiar with. Oftentimes, if you ask a patient, how do you describe your pain? They just look at you like, what? What do you mean? And so I usually give them like 5 or 6. Like, is it stabbing? Is it unbearable? Is it nagging? Is it aching? Is it burning? And usually they'll be, oh yeah, it's aching. And so, but you have to give them a little help there. There's some, pain assessment tools. We're using the 0 to 10 scale because that's, one that we as medical professionals understand, but it's very difficult for patients to understand that sometimes. So describing it the best you can, and maybe they can't pick a number. They can just say it's a kind of bad, it's really bad, it's unbearable. The visual analog scale is where they can point to something if they're not verbal. Slide 11 has some good scales that you can check in or check out. The Wong-Baker scale, again, we talked about that, and the Oucher scale for infants and children. So when we're talking about objective data, physical findings might not always support. So they might have, so many times patients come in for abdominal pain. We do all the tests, we do everything that we can, and there's nothing, right? So this can be very frustrating to patients. So especially for abdominal pains, like what I tell patients a lot is like 50% of people that come into the ER for abdominal pain, we don't find anything. But what we did find out is that that they don't have a disease or illness that needs antibiotics or surgical intervention, and we know that they're safe to go home at this moment in time. So it's not a popular answer for people. A lot of times it's gas, but sometimes you can't see that on a X-ray or CAT scan. Usually you can, but that's why pain is such a tricky thing to assess, and why we call it the 5th vital sign. So some objective data you can look into, if a patient has a broken arm and their bone is sticking out of their skin, that's an objective assessment that should probably tell you that the patient is having pain, right? Or if they have arthritis and their joints are really red and swollen, and they probably just look painful, your objective data is that your joints are red, swollen, and that's how you kind of match those assessments together. Abdominal, like if a patient has a really large mass or their belly is really swollen, that would be another objective data that you could see that might be causing the patient some pain. Some acute pain behaviors that most of us already know already. Grimacing, moaning, becoming angry, sweating, their vital signs might go up, their vital signs might go down. But some people don't exhibit pain that way, right? Some become very quiet, some don't want to talk. And like a patient, just because they don't appear to be in pain doesn't mean that they're not in pain, which is kind of a hard assessment technique to grasp, I think. Chronic pain, patients with chronic pain, they can be very frustrated. They can, they kind of adapt to the pain, they're used to the pain, and they could be sleeping and then they wake up and they're in pain, and that's one that that's a bias I have, because I feel like if you're sleeping, like, right, and then you wake up and then you're moaning and you're in pain, I know that that's my bias, and I know that you can still fall asleep when you're in pain, and that can be a coping mechanism. So just knowing that they can wake up and still have that pain. Okay, we made it through week 1. So I will see you guys all in lab on Thursday and also via Zoom on Wednesday.